I get the wonderful privilege of introducing our visiting speaker today. This is Dr. Nan Raghuraman. She is visiting us from WashU in St. Louis. We were co-fellows for 3 wonderful years, and she is one of my closest friends still, and this is the privilege of training with amazing people. So Nan is a board-certified MFM specialist and physician scientist at WashU in St. Louis. She did her medical training at the University of Alabama, Birmingham, OBGYN residency at Beth Israel Deaconess Medical Center in Boston, and MFM fellowship at WashU in St. Louis, where she's been on faculty since 2018. She currently serves as the chief of the Division of Clinical Research and MFM Fellowship Program Director. Her research expertise is in intrapartum interventions and implementation of evidence-based labor management with the goal of optimizing maternal and neonatal morbidity at the time of delivery. She was the recipient of a K23 award from the NICHD and the SMFM AAOGF Scholars Award. She currently is leading 2 R01 NIH-funded studies investigating the effectiveness of maternal oxygen supplementation in labor and redefining adequate uterine contractility during induction of labor. She has authored over 90 manuscripts related to clinical obstetrics and high-risk pregnancy outcomes. And welcome, Nan.
Great. Hi, good morning, everyone. Slightly embarrassing to have your friend read your bio, but thank you for the very warm and kind introduction. And it's so nice to be here. It's great to come check out Janine's stomping grounds, but also see a lot of other familiar faces in the audience. And I'm really grateful for the opportunity to come talk with you guys today. I'm speaking on a topic that is based on implementation science. And although the title refers to labor and delivery, I think a lot of what I'll be discussing today is applicable to any and every field within OBGYN and even outside of OBGYN in terms of taking initiatives and taking evidence and moving it over to clinical practice, which is always much easier said than done. I have no disclosures. So just as a roadmap for the talk today, I'm going to start by talking about the current state of the science on labor and delivery and a little bit of my soapbox for why research is needed on labor and delivery. And then I'll have an overview of obstetric implementation science, and then my personal favorite topic, which is de-implementation in the world of OBGYN. And then I have a final couple of slides for our trainees in the room in terms of how even the smallest of research projects can really make a difference clinically. So let me start with an argument for why we need more labor and delivery focused research. And obviously I'm biased because that's what I do. But this is kind of my my spiel for that. So in the United States, we have over 3 million deliveries per year. And despite our best attempts to give moms and babies the best possible outcomes, about a third of those patients end up with major abdominal surgery, like a C-section. And despite being born full term, about 250,000 babies are at risk for morbidity, which really kind of speaks to the continued work we need to do to optimize labor management and even pregnancy management to get more healthy full term babies. And the point that really kind of stood out to me as I started doing this work is that the average new mom will pay over $4,000 for her labor and delivery experience, despite having private insurance. So that really speaks to the need for cost-effective care on labor and delivery. And I'd argue that before we can even talk about the cost piece, we have a lot to figure out on the effective piece first, so that eventually we're delivering care that's affordable and meaningful. So there are 2 major gaps that I think plague obstetrics and probably plague a lot of the world of healthcare in general, but specific to OB. The first is that there's a lack of evidence-based practices. So if you look at all of the sort of ACOG practice bulletins, or now called clinical practice guidelines, only 1 in 15 recommendations are based on RCTs. And that, it's impossible to have an RCT to answer every single question in our field. However, 1 in 15 is pretty low compared to other fields within healthcare, right? So if you compare it to cardiology or even endocrinology, their recommendations are certainly based on far more rigorous evidence. The second problem that I think plagues us is the lack of implementation when there is evidence. So that's what I'll spend some time talking about today. But one is postpartum 2-hour glucose tolerance test, which we know is helpful in terms of diagnosing diabetes postpartum. But close to 60%, sometimes more, of our patients don't undergo that test, and that highlights an implementation issue in terms of how we're screening our patients postpartum. If you look at, this is actually like a table from a review of first stage of labor interventions. This is like one of many different tables in that particular review. And if you look at all the things that we do during the first stage of labor and look at the quality of evidence and the strength of the recommendation, the majority range from low quality evidence to moderate, giving us fairly weak recommendations across the board, maybe a handful of strong recommendations. If you compare that to something like cholelithiasis, which impacts far less people in this country, the level of evidence is much higher and the strength of recommendation is much higher as well. So it just sort of speaks to the room that we have in the world of OB to make higher quality, to generate higher quality data and give stronger recommendations. So this is the traditional way that we think of research and trial design. So that movement from basic science to human studies to patient outcomes, and then finally to practice and to community. These last two spaces here, practice and community, is where I think implementation science plays an important role and what I'll focus on today. So the very traditional perspective of bench to bedside with this, cute straight arrow is really outdated. It's not so easy, not so straight of an arrow, because I think that straight arrow makes the false assumption that providers know how to easily interpret and adapt evidence into their practice. And we know it's not as simple as reading a paper and then moving it over into your practice the next day. It certainly requires buy-in from different stakeholders, health systems, et cetera. On average, just because there is a high quality RCT on a particular topic, it doesn't necessarily seamlessly translate into practice. So across healthcare, it takes on average 17 years for research evidence to make it into clinical practice. So that number is derived from a kind of a series of estimations in the flow of original research into sort of the pathway of grants and papers and guidelines, et cetera. So 17 years, that's a long time. I actually think for some reason in the world of OB, at least, maybe less so in GYN, that timeline is shorter, because as soon as we have an RCT on something, we're like very quick to jump on it and implement things, which I think just speaks to how starved we are for good data in the world of OB. So when we think about the movement of evidence into practice, it's multifactorial and has many levels of influence. So that's what this figure is demonstrating. And in order for evidence to be successfully integrated into practice, these are the spheres that sort of have to be addressed. So if we start at the top with the patient, that particular intervention has to be acceptable to a patient. It has to be equitably delivered to patients, and not just patients, but their family members, their friends, the folks that they are influenced by. The second sphere is the provider, and I will tell you from personal experience that I think this is probably the hardest one to influence. And so providers, of course, are influenced by their personal experience, where they have trained, who has trained them, medical legal considerations. And then organization is obviously the next level and a much bigger take on, but we're talking about at that point an intervention that is acceptable to not just a single provider, but a community of providers. So an entire labor and delivery unit, an entire department, hospital system. And then lastly, policy, which in our world is mostly referring to national guidelines. So do we have buy-in from ACOG, SGO, SMFM to implement some of these evidence into practice? So I'm going to walk through some examples in the world of OB at least. So this is obviously the ARRIVE trial, which all of you I'm sure are very familiar with. This was a multi-center trial that was done in 2018 or published in 2018 that demonstrated that induction of labor in low-risk nulliparous patients was associated with lower cesarean delivery and no difference in adverse perinatal outcomes. And this was really like, in the world of research, at least, like the highest quality the data that you can generate on a particular topic. It was multi-center. It included both community and academic centers, some diversity in patients, although probably some room for improvement there. But in general, this is the best it's going to get in terms of the type of research we can do. So to answer this particular question. And so based on this data, SMFM and ACOG released their recommendation that said that it was reasonable to offer induction to low-risk nulliparous patients at 39 weeks. And you can see that they've worded it in a way that is not a strong recommendation, but rather do it if you want, right? And that, to me, is interesting because if you, in the world of research, if you generated the best possible data that could give you the strongest recommendation, you can see that this is not worded in a way that it is a strong recommendation, and that is purely because of implementation factors and to allow providers and health systems to have some leeway in their interpretation of this data. So this is one example I'll share with you in terms of a lot of barriers that people have experienced for implementing this particular intervention. But then I want to compare it to another intervention that has been far more easily implemented across the board. So this is, again, a very similarly designed multi-center trial looking at giving adjunctive azithro at the time of cesarean delivery for anyone who has a non-elective C-section. And there was demonstration of benefit in terms of reduced risk of postoperative infection. And again, ACOG had some vaguely worded suggestion of like, do it if you want, which is the addition of azithromycin to a standard regimen can be considered, may be considered for women undergoing a non-elective cesarean delivery. And I don't know about your L&D unit, but for us, this was implemented the next day. Across the board, everybody got azithromycin. So you can see how two same quality studies are implemented in two very different ways, where one has multiple challenges across the board. Meanwhile, this one, like azithromycin, is easily implemented the next day with no pushback from anybody. So that really, I think, speaks to some interesting work to be done in the world of implementation science, in that it brings us back to these fears, right? So if we're thinking about, for example, the patient perspective, we go to elective induction of labor. The patient perspective of that is thinking about acceptance. Is this something that patients are interested in? What is their knowledge about the benefits of an elective induction, or their concerns about harms of an elective induction? What is the peer pressure that they're experiencing when it comes to things like social media and friends and family? If we think about the provider and their perspective when it comes to offering elective inductions, perhaps they're influenced by how they trained, where they trained in residency. It might have been that they trained in a place where this is not done regularly, or that they've experienced anecdotally adverse outcomes as a result of offering elective induction. Their knowledge and beliefs about induction, and then certainly medical legal concerns. And when I talk to you guys about sort of the work that we've done with oxygen, this is one that came up often, is the concern about litigation if they don't offer a particular intervention, or if they do offer a particular intervention. At an organizational level, I think this is probably the biggest hurdle that the ARRIVE trial, the results of the ARRIVE trial have experienced. So obviously, it's not just up to a single provider in terms of how elective inductions are offered. This is certainly some organizational considerations here. So operations, staffing, do we have enough rooms to accommodate more elective inductions? Do we have enough nursing, postpartum beds, et cetera? Certainly cost is a consideration there. And then of course, culture in terms of how evidence is received at a hospital level and how that ties into cost and revenue. And then a policy, of course, we talked about already in terms of ACOG and SMFM's thoughts on those particular issues. So this brings us to what implementation science is and what the sort of steps are for implementation science. So the formal definition of implementation science is the studies of strategies to promote the uptake of evidence into clinical practice in a meaningful way. And in order to have effective strategies, you also have to study what influences whether folks are interested in participating in a particular strategy. And that's at different levels, the different spheres that we talked about. So, so not just strategy, but also factors that lead to successful strategy. To overall, of course, the end goal there is to improve the quality of health and to align it with research that is being done in the space. That implementation science is done to really address two major gaps. The first gap is looking at the translation of sort of the quality of service that we currently are delivering. So if you look at that across the board, this is not just an OBGYN, about a third of patients don't get treatments of proven effectiveness. And right now, if you look at that in OBGYN, I would guess, I really don't have data, but I would guess that it's somewhere in the similar realm. And about a quarter of patients get care that is not needed or potentially harmful, also applicable to the world of OBGYN. The second thing that implementation science addresses is the care that could be. So what is our ideal scenario and how can we optimize what we currently offer to give the care that could and should be? That brings us to implementation outcomes because you can either have an effective intervention that's poorly implemented. So, elective 39-week induction is just one example. But also similarly, you can have ineffective interventions that are very successfully implemented. So 17-OHP is a very good example in the world of MFM, which very, very quickly got de-implemented in the past year or so. But even before that, the data for the use of 17-OHP was kind of mixed. And then we have other things in the world of OB, like the use of tocolytics that don't really have strong data in terms of prolonging pregnancy, but are very widely used and implemented in many protocols for preterm labor management. So that just is sort of, you can have a full spectrum of implementation conundrums in a particular field. So in the way that we're used to traditionally thinking about clinical trials, there are ways to sort of build in implementation pieces into it, which I think is for the push for a lot of research in this day and age. But a traditional clinical trial takes your what, which is your intervention. And I just listed a couple of like OB specific ones on this slide. And then it looks at the effect of that intervention on patient outcomes. This is the traditional trial that we're all used to reading and interpreting. And we'll look at the intervention and its effect on a meaningful patient outcome that could be a symptom, it could be a particular diagnosis, satisfaction, et cetera. But when we build in implementation science, we look at the how. So we don't just look at a what, but how can we move that intervention into practice? And that is a completely different set of outcomes than what we're traditionally used to looking at. So those outcomes are the ones listed on this slide. And then I'm going to go through a little bit more in detail because they're just not the traditional way that we're used to thinking about research. So the first one, feasibility, is essentially like how practical an intervention is, right? So like, is it suitable for everyday use for, a practicing physician or provider of any kind, really. Second is fidelity, which is how true are we to delivering the intervention in the way that it's supposed to be delivered. So if it's supposed to be a medication that's prescribed for 14 days, but we end up really prescribing it for 7 days, that's a difference in fidelity. The next thing is penetration, which is how widely that intervention is taken up at a system level, and how accessible is it to folks in one clinic versus another clinic. Acceptability is straightforward, is sort of how satisfied a particular provider or stakeholder is with your intervention. Sustainability is another one that I think is quite important and understudied, but how the durability of an intervention, right? So you guys are probably familiar with when there's an exciting new intervention, there's a spike in uptake, and then there'll be a quick drop over, or not necessarily quick, but slow drop over time. And then that kind of drops out, and that's not a sustainable intervention. So sustainability is an important thing to like keep studying even after you've launched a new intervention. Uptake is, of course, like the providers that have chosen to use the intervention, and then cost honestly could really be a talk in and of itself in terms of how to build that into implementation science. So before identifying the best way to implement your strategies, and I bring this up because this is not just relevant to research, it's relevant to any intervention that you may take on clinically. So even if it's the smallest of project that you want to launch, or you want to change a protocol on your labor and delivery unit or in your clinic, you want to start doing a new, approach to screening, new kind of QI intervention on your floors, all of these next few slides really apply to you in terms of how to strategize that movement, because we all know that the approach of saying, now you will all go do this, doesn't work, right? It just does not work to say like, please start doing X now, or please stop doing X now, because it requires a little bit more strategy than that. So before identifying that actual strategy, the first task at hand is to get a lay of the land in terms of your context for implementation. So what do I mean by that? Well, before I roll out a grand strategy to get people to implement my new intervention, I have to first understand why it already hasn't been implemented. So why isn't there already buy-in from folks to do this particular intervention? So the things that you want to think about there are, who are the stakeholders? So like, who are the decision makers? Who are the people that sort of participate in the decision making about whether the intervention should be used or not? What are their particular barriers to using the intervention? Is there even a demand for a change in practice in this scenario? And then one really important piece is to follow the money, right? So like that, it applies to like a lot of things here, but if you follow the money trail, you get a sense of stakeholders that perhaps you hadn't really traditionally thought about, and that should really be at the table discussing the intervention as well. And that includes usually folks like hospital administrators, payers, et cetera, which really kind of opens up a kind of more complex scenario in terms of your implementation. Once you've identified your barriers, that's when you can pick an appropriate strategy to implement. So if the barrier that you've identified is that a lot of folks just don't know that a particular intervention exists or that it's beneficial for patients, your strategy then is to educate folks. And interactive education sessions is kind of easier said than done, but certainly doing things like sending an email with information don't really work anymore in this day and age, because everyone has email fatigue. So if I send you a long email about the benefits of my intervention, unlikely you're going to read it. So you have to find kind of novel and creative ways to educate folks about your intervention. It might be small groups. It might actually be physically walking over to clinic yourself or your unit and talking to folks about why this particular new intervention is helpful. Certainly things like lectures and grand rounds, et cetera. The next barrier that you might come across is perception reality mismatch, which this is kind of an interesting one for me, because this is where the provider or the stakeholder might feel like, well, we don't do that here, or that's not a problem for us here. So it's not, I never see this particular type of patient, so this intervention is unlikely to be helpful. That's where audit and feedback might be helpful. So for example, in the oxygen stuff I'm going to talk about, a lot of folks say, well, we don't really use oxygen anymore. But if you audit what's happening on their labor and delivery unit, they may not, but their nurses are applying oxygen. So that kind of strategy might help in terms of delivering some objective numbers to say, I hear you, but these are what the numbers are saying about your unit. So there's some mismatch in terms of, perception and the reality. The next is lack of motivation. This is like, I think, a very fair barrier and probably applies to everyone across healthcare because of burnout and many demands across the board for providers and for patients. But this is where things like incentives can help. Sanctions, which is like a little bit more drastic, but a proven implementation strategy is like, if you aren't following the new protocol, then your X privileges get revoked, or you don't get whatever access to this particular benefit, et cetera. So more drastic, but definitely proven in other fields of medicine. Beliefs and attitudes. So this is probably the barrier that I think is the hardest to overcome of all of the things listed on this slide, because beliefs and attitudes are ingrained in many different things, and it's hard to really overcome that with a single intervention. But the one that's evidence-based in terms of making a difference in this space is having champions or advocates, so peer leaders and opinion leaders that can help shape and influence others. So if there's someone that's well respected in your particular field, or a nurse that when I'm speaking to labor and delivery things, a nurse that is more willing to sort of talk about evidence-based medicine and is really respected by his or her peers, that might be a person to kind of loop in on your team as a potential advocate and opinion leader. And then lastly, systems of care. And this last row is almost laughable because process redesign is easier said than done. But that is some of the things to think about in terms of maybe the process shouldn't just be that I put in an order and then expect for it to happen. There's probably some follow-up, et cetera, that has to be done to enforce the strategy. So this brings me to our a subtopic within implementation science, which is de-implementation, and it's somewhat of a newer field within implementation science. This is a quote from John Maynard Keynes, who was an economist during the Great Depression. And he said, "The difficulty lies not so much in developing new ideas as in escaping from old ones." And this is something that I think really speaks to the work that's being done, de-implementation across healthcare, in terms of removing ineffective practices. So a de-implementation itself is essentially the process of abandoning these ineffective or even potentially harmful interventions that are so deeply rooted in our practice and really hard to peel away. Those interventions account for about 30% of our current healthcare strategies. And you guys might be familiar with the Choosing Wisely campaign. This was started by the American Board of Internal Medicine several years ago, but it was an initiative to really minimize the use of ineffective interventions and their recommendations for choosing wisely within each specialty. So OBGYN has a whole host of things, and this is really just a screenshot of a couple of the things that are on there from a general OBGYN perspective, things that I think at this point for many years have been sort of brought up in training, so much so that I think you guys are probably familiar with a lot of these. And it might seem straightforward to us, but may not necessarily be straightforward to everyone in practice. So when we think about sort of stopping some of these practices that might have been routinely done in the past, there actually is a formal process for de-implementation. It's not just that you can say, now please stop doing this, and everyone stops doing it. There's a formal process for sort of peeling away these interventions so that you can first figure out why folks are so wed to them to begin with. And then you figure out how you sort of investigate your strategies for taking them away in a stepwise process so that folks don't feel completely abandoned, like all of their options are no longer there. So I'm going to walk you through my personal story of de-implementation in obstetrics as it relates to the practice of oxygen for fetal heart rate tracing. So when I was a resident, this was something that was ingrained in the brains of every person that walked onto L&D. So every nurse, student, resident, midwife, provider, whoever it was, if there was a decel or any, concerning fetal heart rate tracing, you gave an oxygen mask to the mom. It was one of the first things you did when you walked into a room. In fact, most of the nurses would have probably already done it by the time you walked into the room. And when I was a resident, I remember thinking like, gosh, it's like so interesting because like what she's already like satting normally. So why is this going to be helpful for a fetus? So that is what sort of inspired some of my work in fellowship. But I was really naive to think that that the movement of evidence related to this could be as simple as do the research, change guidelines, and then change practice, because that's really not how it has shaped out. And that's what sort of brought me into the world of implementation science. So in terms of oxygen supplementation itself, as you all know, up until recently, it was widely performed because the theoretic rationale there is that if we hyperoxygenate mom, we are transferring some of that oxygen to the fetus theoretically, and then reducing the, changing fetal hypoxia and preventing that transition from fetal hypoxia to acidemia, which we know, obviously acidemia is the outcome we're trying to prevent here, because that is linked with adverse neonatal outcomes. And this practice was really originated in the 1960s and 70s after there several animal model studies that showed benefit. And the first human study in 1967 showed that it was like 21 patients, and they gave face mask oxygen, which, like, you might be wondering why even face mask is a thing, because that's not how we normally give oxygen, right? We escalate, we do nasal cannula, we escalate. But for this particular intervention, it was always just like slamming a patient with a non-rebreather with a lot of oxygen. And that originated from this data that showed that, when you give a patient 100% oxygen face mask, that it eliminated late decelerations, which is not what they were called back then, but is essentially what they are now. So, and it was officially recommended by ACOG for years and years and years. So this is actually a screenshot of ACOG's document, which has since changed or is being changed. And administer maternal oxygen was a recommendation for the response to category 2 or category 3 tracings for decades. It wasn't really until the 2000s when this practice was really called into question. But if we delve into the kind of science of and the biologic plausibility of this practice, it gives us a little bit of pause. So this is an hemoglobin dissociation curve, which I think many of us have probably blocked out from our memories, but I will help refresh your memory. So this is most people that have normal oxygen saturations are hanging out in this area of the curve. And by giving somebody additional or supplemental oxygen, it is really unlikely that you're sort of increasing the PaO2. You're not really changing how much oxygen is being unloaded at the level of the placenta. And so the chance of actually transferring more oxygen to the fetus is pretty slim in this area. And obviously, we're in a different space when we have a mom who has a low oxygen saturation. This is really referring to patients that have normal oxygen saturations. So this is an editorial that was written in 2013, and is really one of the things that kind of prompted me to want to research this a little bit more. It was written by an MFM, a couple of MFMs at the time, and they were the first, at least publicly, to call this practice into question, and really highlight where there was not enough data to keep practicing. So what are the main reasons to kind of readdress this practice besides the biology of what I just explained? One is that it might actually be harmful. So in addition to data now that's growing in pregnancy, certainly at the time, like 2013, et cetera, there was an abundance of data on how hyperoxygenation outside of obstetrics is associated with harm. So at least in the pediatric literature, we know that hyperoxygenation is associated with adverse outcomes like bronchopulmonary dysplasia, retinopathy, abnormal neurodevelopment, so much so that the American Academy of Pediatrics then changed their guidelines to say initial neonatal resuscitation should be done with room air instead of supplemental oxygen. And then there's definitely a growing body of evidence in adult non-pregnant literature that over-oxygenating patients is associated with harm. So the AVOID trial was a big trial in the world of cardiology, where they gave supplemental oxygen to those presenting with an MI, and found that months later, the ones who received oxygen actually had larger infarcts than those who didn't get oxygen. In the ICU world, this is just one trial, but there are now really a handful of trials that show that the strategy of liberal oxygen supplementation is associated with increased morbidity and mortality. So that growing body of literature outside of pregnancy really calls for more judicious use, I think, even within the world of OB. The second is resource utilization. So really, among all the things that we do for a patient on labor and delivery, oxygen is pretty cheap and not really an expensive intervention. But I think the COVID pandemic taught us that oxygen is a very precious resource. There are places in the world that ran out of oxygen during the pandemic. And certainly this highlights that, and although a patient is not directly billed for oxygen, it is a hospital level cost in terms of providing oxygen. And so it is money that's accounted for in some form or fashion. And so I think this plus the use of a very precious resource is something to be considered. And then lastly, and probably most importantly, is that it's not really effective. So it's not doing what we think it's doing to address fetal hypoxia. So I'll review some of the work we've done to sort of highlight that particular piece. This was a trial that we did at WashU several years ago, looking at oxygen versus room air in patients with category 2 tracings in labor. And we looked at the outcome of umbilical cord lactate, which is kind of a surrogate for pH, but perhaps even better because it changes before pH does. So if oxygen is really helping address hypoxia, then we should see improved lactate levels in that group. But as you can see in this particular graph, the lactate levels were very similar, almost identical between both the groups. And then we also looked at, well, maybe it's not fixing hypoxia, but is it making the tracing look better? Is that at least helping us from that perspective? And when we looked at whether recurrent decelerations resolved with the use of oxygen, there's really no difference between groups. And my favorite thing about this particular set of data is that 86% of recurrent decelerations resolved with room air alone. So that just sort of speaks to perhaps some of the other interventions that we're doing that might be helpful. So this is, then we put all the data together because our trial was certainly not the only trial to be done in this space. There are close to 16 different trials and more since then that have looked at this particular practice at the time of scheduled C-section, et cetera, prophylactically during labor. We pulled all that data together and looked at the outcome of umbilical artery pH, and found no difference there between oxygen and room air groups, which kind of supported our initial results. And we looked at things like APGARs, NICU admission, also no difference there. But one of the limitations is that we don't have a lot of data past the surrogate outcomes of cord gases, pH, other meaningful neonatal outcomes we are missing. But in 2022, ACOG did change their guidance to now recommend against the routine use of oxygen supplementation, which for every researcher is kind of like a dream come true. We thought it was like a huge cause to celebrate. Like our team kind of had a little party, we celebrated, et cetera. But very quickly thereafter realized that that's actually where a lot of our hard work began, and that it's certainly not where it ended. So after ACOG changed their guidelines, we did a national survey fairly recently of a little over 500 labor and delivery staff throughout the country. So it included nurses, midwives, physicians, really anyone that takes care of a patient on labor and delivery. And in our survey, about 49% of folks, stakeholders, reported continued oxygen use for fetal resuscitation. And about a quarter of folks, even if they didn't use oxygen, knew somebody else on their L&D unit who did use oxygen to respond to fetal heart rate tracings. And as you can see, it kind of is spread across all different provider types in terms of continued use. And if you ask about the rationale for continued use, it's also really across the board. And you could pick different multiple answers here. So the numbers might not necessarily add up to 100%, but most people used it if nothing else worked. So they've done all their other intrauterine resuscitation and it's the last thing left. So they do it then. 25% of people still think it's an effective way of managing fetal heart rate tracings. And 32%, and this one is one that really stood out to me, felt that it didn't hurt. So that really spoke to perhaps some of lack of awareness about the safety data with over-oxygenation. So if we go back to kind of our spheres of influence and think about all the factors that play into de-implementation of oxygen on labor and delivery, our next step was to figure out, well, what are the barriers for de-implementation? Why do folks like using this practice, and why is it hard for us to peel that away despite having a national recommendation? So the policy piece was taken care of, but really the other spheres were not addressed. And so we chose to focus on the provider piece because that seemed to be the most influential piece. And so we kind of studied to get at this a little bit more. We did a survey of 6 different labor and delivery units within our hospital system. So it included both university affiliated and non-university affiliated hospitals, and had nurses, midwives, and physicians respond. And we sort of asked about, like, what are the things that motivate your clinical decisions on labor and delivery? When you're taking care of a patient, what are the things that influence your decision to administer a particular intervention? And this, we weren't necessarily talking about just oxygen, but in general, like what are your motivators? And the things listed in this box are the things that we asked about, right? What do you think about your prior experience? You know, your literature, evidence, the patient's preference, et cetera. And the results are kind of interesting. So if you look at nurses versus delivering providers, the nurses were more likely to rely on things like prior experience and recommendations from other providers, i.e. the physician putting in the orders. And then the delivering providers were more likely to prefer things like literature and evidence to guide their decision-making. And then collectively as a group, and in order of influence, both were really influenced by professional societies and their recommendations. And this comes into play on the nursing end, and just I'll mention that. But the other things were invasiveness, what's available in terms of equipment, and then lastly, for all groups, was patient preference. So that was the least considered factor in decision making. The timing of this was quite interesting because around the same time as when AWON, which is the governing body for obstetric nurses, released their recommendation to essentially keep using oxygen. So their recommendation was that you should give it for at least 15 to 30 minutes. Like where that timeline comes from is unclear, but they recommended continued use essentially on behalf of the nurses to give them some way of performing intrauterine resuscitation, but also, to be fair, citing the fact that we don't have any meaningful data on neonatal outcomes past some of the things that I already mentioned, like cord gases, et cetera. We lack data on whether giving oxygen actually prevents things like hypoxia, brain damage, et cetera. So that was a reasonable point. So that actually was the impetus for our current ongoing trial, which is the MOXIE trial. It's our multi-center trial looking again at oxygen versus room air, but this time looking at some real outcomes of neonatal morbidity. So to get to, in our implementation sphere, if we really want to be able to change the nursing organization's mind, we're going to have to provide them the data that they want to see to make that change. So that is the goal here. And simultaneously, we're going to start trying to study a little bit more about, acceptability on the patient end too, in terms of, how they feel about oxygen and then the provider piece as well. So, I talked a lot about oxygen, but certainly there are other examples of implementation science in obstetrics that I think are going to be real things for us to deal with in the next couple of years. So the other examples I have for you are like 17-OHP was probably the most successful de-implementation story in obstetrics, right? If you take it off the market, no one can prescribe it. So that is the best way to de-implement something. The other things that are coming up for us as a field, AI, I think implementation approaches there are going to be really important in terms of how to build it into clinical practice. And I think thinking about our spheres there is going to be particularly important. And then one other kind of active area that I think we're trying to do some work in, and that others are as well, is vaccine uptake. We certainly are doing a lot of myth busting when it comes to vaccine related concerns, but also now that we have RSV vaccine, that's another place for implementation science to do its work. Ultimately, there will probably be a GBS vaccine, so that will be another area for us to work on as well. And then I'm guessing you guys, are you guys using biomarkers for preeclampsia prediction. Yeah, good. Keep it that way. So like this is like a new thing for us, at least at WashU. And this is certainly an implementation conundrum in terms of thinking about all of our spheres here. So like, the patient who's read about biomarkers, like Time Magazine just had this whole thing on like using predictive tests in pregnancy. So our patients come to us asking about it. Providers who have strong feelings pro and against it. Organizational level things like is this a reimbursable test? Can we bill for this kind of test? Do we need extra equipment in the lab? There's so many sort of things to consider there besides just making a policy or a protocol that says we're going to start sending it now. It just doesn't work that way. These are the spheres that we need to think about. So I'm going to end on a quick note for our trainees that are in the room, for like the residents and fellows that might be here. And I'm preaching to the choir a little bit because you guys as a department are quite productive on the research end and have a phenomenal kind of infrastructure for doing research. My like pearls for residents as they're kind of thinking about what to work on the research end is to question a little bit of why we do what we do. But not in an obnoxious way. So like, don't be the person that's like constantly questioning, but for some things that you're routinely prescribing, that you're routinely recommending, look up the literature and think a little bit about like, well, why do we do this? And is there data to support the regular use of this? Or if you notice, it's easy to get frustrated when you have 10 different attendings that do 10 things differently. But use it as an opportunity to think about whether there's an opportunity to do some research in that space, right? So like if we're doing things 10 different ways, it probably means it lacks literature. So that's something to think about as a potential research question. I always keep a list. So I have one on my phone of like research questions that kind of pop up on my mind when I'm on rounds or in clinic, just so I can circle back, because you're not going to have time in the middle of a busy clinic to like do a lit search, right? So that's just something when you have like a little bit of downtime to think about so that you can generate your research question. And then of course, like I encourage you all to read. So the ACOG CPGs are a great resource, because they now highlight areas where we don't have a lot of data, and those might be the areas to think about as you're thinking about potential research question. But I want to tell you guys a little bit of a story, because I know many of you, and this is like natural, this happens at every place. Like most people are like, I want nothing to do with research, right? I just like, I'm going to do the bare minimum to like graduate and do whatever project I need to do. Because most people don't feel like an natural affinity towards doing research. I'm going to do what I need to do, and then I'm going to graduate. But I'm going to tell you about a story about one of our residents who came to us, let's see, I think it was like probably her second year of residency. This is Allie Rubin. She's now graduated. She's a phenomenal generalist at Northwestern now, but she second year said like, Nan, like, can you help me do a project? Because I have to do one, but I hate research. I just want to I want to do it because I have to do it. I need to present this project at the end of residency because I have to, but I really would like nothing to do with research. Okay, understood, Allie. So tell me like, what are the things that like motivate you? So we sort of talked about the things that are important to her, sort of like struck her during clinical practice. And one of the things that really stood out to her was this practice of doing the indications for urine drug screen on our labor and delivery unit, one of which was isolated marijuana use. And in her observations, when a patient had isolated marijuana use, we'd be sending a urine drug screen that would then lead to sort of a biased approach to the care of these patients. We were sending a lot of urine drug screens in our Black, young, uninsured patients, and that was leading to downstream sequelae related to social services, et cetera. And really the original intention behind making that an indication for UDS was the concern that there might be other co-substances that we would find when someone reports marijuana use. So the project that she took on was looking at, well, how often do we find something else in their urine drug screen when they have isolated marijuana use? And her answer that she found through her data was that only 1% of the time do we find some other substance. So this really seemed like an ineffective strategy and a kind of poor indication to do a urine drug screen on our unit. She presented that to our hospital, our local hospital. And that then spread like wildfire to the other L&D units within the Barnes-Jewish Hospital system, which again includes community hospitals that are not necessarily university affiliated. And she changed the protocol at all of these hospitals to remove isolated marijuana use as an indication for a drug screen. And her protocol change resulted in a pretty dramatic decrease in the number of UDS that we were sending across all of our units. So, and this had a direct impact on our patients and some of the disparities in terms of who was getting flagged by social services, et cetera. So this is like the end result of somebody who wanted nothing to do with research. So I love using this example, and I tell Allie all the time, she's like part of my show here, because she really made a huge difference by just having a thoughtful approach to implementation and thinking through what some of the barriers were that both providers and patients experience. And her, no matter how small you think your project is, it can really have a meaningful impact. Hers had an impact across an entire hospital system. So I'll end on the note that we really have a lot of work left to do in the space of women's health. You guys know this as well as anybody else. And these statistics as it relates to chronic disease burden and maternal mortality are certainly ones that you guys are familiar with. But as we start designing research and doing these multi-million-dollar trials to address intervention, I think it's also important to build implementation science into those trials so that we don't just have a trial with results that really stand out that we can't move over into practice. So this should really be the face of every research moving forward. So I'll end on that note. Thank you so much again for having me here. And I'm happy to answer any questions that you guys have. Please come visit us in St. Louis if you guys are ever around.
Thank you, Nan. That was an awesome talk. Does anyone have questions? I think we're kind of coming up to time, but if anyone has any questions. Okay. Lovely. Oh, Dr. Hartenbach has one.
Thank you so much. That was just really a fabulous talk. One thing I've observed in my world, in the cancer world over the past 30 plus years, is when people like the results of an RCT, they'll jump on. And when people don't really like the results of an RCT, they figure out they're really smart. The smarter you are, the better you are at trying to argue against the evidence of the RCT. So, I think that all your comments are just kind of fabulous. I'm not sure what my question is, other than saying I really appreciate you bringing this topic to the department, because I think this is just so vital and inspiring people to get involved in not just the research, but the sort of how do we get things that have been studied and have been found to be beneficial to the patients. And my final comment is, like, the last thing I wanted in labor was a face mask. That's all I can say.
Yeah, thank you for your comment. And it's funny. Yeah, we all like data that like confirms our biases, right? So like, I think whenever we see a trial that supports what our personal biases are, we're quick to hop on board. But this is why I also think part of what's important for any resident education, not just an OBGYN, is interpretation of randomized trials. Because I don't know, I think in most academic institutions, we do a good job teaching someone to look at a trial and think about strengths and limitations, but I'm not sure that that's universally done. And I think that's an important skill set to have, so that we're not just affirming our biases every time a trial comes out, that we're able to like critically appraise everything that's published, regardless of whether we like the results or not. But yeah, I think that is pretty important. And I think that really speaks to like that provider sphere as well in terms of like, do I like the results or not? And then, yeah, a face mask. It's funny because the oxygen bars in Vegas that like that they have, like people think that the more the better for oxygen actually. And that's why you get charged like $30 to go sit, have a nasal cannula on for like an hour. I did that once. It's kind of funny, but I think it just, the general notion for a lot of things in this country especially is the more the better. And I think oxygen is one of those things where patients actually, I'm now in a situation where I have more providers that are less interested in giving oxygen. So they're like, oh, do we really need to keep doing this trial? Like I thought we were done with oxygen, but it's the patients that are like, you're not going to give me oxygen. Like they are the ones that are more concerned about it than the providers are. So it's interesting.
I have one question. Luther Gaston, OB. Do you think that we use the p-value too much as more of a dichotomous kind of approach instead of it being more of a nuanced approach, and particularly for therapies that may not be harmful? I mean, oxygen is not clear that that's not harmful. And so that may be different from, say, progesterone in someone who has had a miscarriage and bleeding like the UK does. And so that the question is, when we're looking at the research, is really interpreting, because if we have somebody that has a kind of reduction, that reduction of a certain percent for hysterectomy, for C-section rather, may have some type of clinical significance, but it may not have statistical significance. So
Yeah, that's a great question. Oh, sorry, I didn't mean to cut you off. Did you?
no, go ahead.
No, I think it's a great question. I mean, I think a p-value is a suggestion. It's not really a rule. So if without getting into like the weeds about statistics, a 0.05 is really kind of an arbitrary number if we think about it. So I think your point is very well taken. And I always train trainees to think less about the p-value, and sometimes I find the values of a relative risk or an odds ratio to be maybe a little bit more meaningful, and that it tells you more about direction of effect, and thinking about things like a confidence interval tells you a little bit more about precision. But more importantly, the ability to pool all of those data together in a meta-analysis is probably the most helpful, right? And so I think that's probably where if you're thinking about kind of the pyramid of level of evidence, meta-analysis is at the top because it allows you to rely less on a p-value and more on abundance of data, which I think is more helpful. And PS, meta-analysis is something that I feel like an easy trainee project. You don't need any resources. You just need like the internet. You need the internet and a partner in crime, and it's a completely doable project for anybody. So that's another one that I'd like to go ahead and get on my soapbox about. So think about it for the residents.
Yeah, meta-analysis. I just say yes to meta-analysis. I think we need to cut you off there. I'm sure there's many more things we could talk about. Really, really appreciate you being here.